All right, everyone, we're gonna get started. I guess panelists, let me know if there's any issue with my mic. Thank you everyone for attending the third webinar in our COVID-19 response series. Today we're going to be focused a little bit more on a more narrow topic based on questions that we received in the last webinars. Specifically around correctional facilities and medications for opioid use disorder. Sorry, excuse me. But particularly during the COVID-19 pandemic, as it relates to all of the emergency regulation changes for the public health emergency. So we can jump right in. So my name is Ken Shotskis. I'm the Senior Program Officer at the Foundation for Opioid Response Efforts. And just a quick agenda for today. We'll start with just going over some webinar logistics and an introduction to the Foundation for Opioid Response Efforts. I'm sure many of you do know us at this point, you know, we think it's worth it to go over some resources that we have again. We will have three panelists today that are going to be going over different areas around corrections, around medications for opioid use disorder, the legal and policy environment, as well as state Medicaid considerations as you navigate this new environment. And we'll end with a question and answer session with our panelists, which we'll go over in a second. The webinar logistics. First off, the webinar is being recorded, as our others were as well. And they'll be available immediately afterwards on our website, www.forefdn.org. The presentation slides will also be made available in our resources section on our website. Importantly, when we get to that, and you could submit questions throughout the webinar, but please use the Q&A button at the bottom of your Zoom screen to submit questions for our panelists. We're doing this so that if you do have a similar question, you'd be able to upvote that question using the thumbs up button. And this will allow us to get to the questions that are the most pressing as according to the attendees here. We will be putting together an FAQ as well with the questions that were asked, as well as questions we could not get to today. And they'll be provided on our website in a week or so. Any other resources that you would like to share with everyone, you can always contact us at info@forefdn.org. And lastly, we always have a brief survey at the end of our webinars to ensure that, one, we're covering the things that you're seeing on the ground. So please provide us with that feedback of how we can improve this so this can be even a better resource for you. So quickly, because we have a lot of great content today, and I want to make sure that we have enough time to go over everything. So our foundation, the Foundation for Opioid Response Efforts, was founded in 2018 with a focus on supporting solutions to the opioid crisis. Our mission is to convene, support partners, advancing patient-centered, innovative, evidence-based solutions impacting people with opioid use disorder, their families, and their communities. And we do understand that this time with the COVID-19 pandemic, that new challenges are now put in place to care for the community. So we are committed to funding a diversity of projects across the spectrum at national, state, and community levels. And we did put out an inaugural RFP and just awarded 19 grants about 3 weeks ago that you can actually see on our website, forefdn.org. You can see the first 19 grants. They're doing a lot of great work around access to treatment for vulnerable populations, including the criminal justice population. But overall, you know, our mission, we focus on 4 focus areas, and that is provider education, payer strategies, policy initiatives, and public awareness. So again, the COVID-19 pandemic has brought new challenges to caring for this population. And FORE is looking for ways that we're able to support and provide broad assistance to you during this really a time of uncertainty and a very quick evolving regulatory environment. We are providing on our website, and you can see an image here, up-to-date resources and guidance as they come in from the agencies and ourselves, speaking with clinicians and such. We are doing these webinars as a weekly series every Thursday at 3 p.m. Eastern. We've already had a few that really looked at federal and state levers for policy changes, and you can check those out on our resources page as well. We plan to have one next week again that is going to be focused on delivering care from the patient perspective, specifically around telehealth right now, and ensuring that patients are comfortable and that they're being involved into creating these new systems in this new environment. We're also looking to facilitate connections with experts for you and the technical assistance to you in any way that we're any way possible. And we're always looking for new ideas that we may be able to support you with. So please submit your ideas to our general email address, info@forefdn.org. And you can again follow updates on our website. We're consistently updating it with the latest guidance. So we have a great webinar planned for you today with a fantastic panel. So we can jump right into this. First up, we have Dr. Nickolas Zaller, who's a professor at the Fay Boozman College of Public Health at the University of Kansas Medical Sciences. And he'll be speaking on medications for opioid use disorder in corrections environment. So with that, I'll let Nick take over.
Thank you very much. Good afternoon, everyone. I wanted to provide a little bit of an overview about medications to treat OUD in criminal justice settings. Some of this will be relatively, most folks are knowledgeable about most of this, and some things I wanted to talk a little bit about in terms of the new challenges that we face within the context of COVID-19. So we already know that the high risk that correctional populations face for morbidity and mortality, especially in the post-release period. We've all read the studies and have heard numerous times over that the period post-release, immediately post-release from criminal justice settings is very high risk for folks in terms of overdose. We also know that medications to treat opioid use disorder really are the standard of care in the community and the gold standard overall. Increasingly, there have been legal challenges to correctional facilities who are not providing medications to treat opioid use disorder, and in some cases, who are withdrawing patients who are incarcerated, who are on these medications. And those policies are being challenged legally. And there's a growing consensus that policies that do not allow for medications to treat addiction in criminal justice are unethical. Importantly, over the last several years in particular, as the opioid epidemic has really taken off, a growing number of prisons and jails are offering medications. And again, this is still limited, but as an example, jails in at least 30 states now offer some form of medication, albeit most often injectable naltrexone. Next slide, please. And I think that most of us also are aware that typically medications to treat opioid use disorder need to be delivered through a multidisciplinary team. And often that means correctional health providers and behavioral health providers. And that may mean general primary care type providers within correctional settings, and then outside behavioral health specialists to come in. So often we know that, especially for larger prisons and jails, medical care, including behavioral health care, is contracted out with community-based providers. And we also know and understand, given the data that we have about the immediate period post-release, that really robust reentry planning and linkage to treatment is of critical importance. And that is particularly the case for folks who are incarcerated and they're on stable regimens of medications, and then they need to get linked back into treatment programs when they're released. Next slide, please. So that is kind of in our best of time scenario. So, you know, that was sort of our wish list when we didn't have a pandemic going on. And as we all know, those are some of those policies and procedures and linkages are challenging. However, we now know that with the novel coronavirus and COVID-19, continuity of care is even more challenging. And really, we see that there is evolving guidance, particularly with respect to protecting both individuals who are incarcerated and correctional staff. We also know that folks with addiction and substance use disorder in general are particularly vulnerable. And we also know that older adults with substance use disorders are especially high risk for more severe complications from COVID-19. The other part of the challenge, and this is, we've heard a lot about this, I think over the last couple of weeks in particular, there've been a lot of commentaries and policy briefs coming out around this. It's very, very difficult for correctional facilities to adhere to some of the public health guidance that we're really promoting in the general population. So, for example, social distancing is very, very difficult in correctional facilities. As many of us know, these are highly densely populated environments where it's very difficult to separate folks. Correlated isolation of suspected and confirmed cases is also very difficult. So typically jails and prison facilities, many places across the country are very, very overcrowded, and there really aren't opportunities to isolate, separate folks who are suspected or confirmed COVID-19 cases. And on top of that, we know that there are a lot of staffing shortages, particularly in county jails. And that's not just in medical staff, but also general correctional staff. And the other thing that I think is important to keep in mind, we typically assume sometimes that correctional facilities are closed environments, but actually they're not, because as we know, people are coming in and out of correctional facilities on a day-to-day basis, largely correctional staff. Even most facilities have banned visitation over the last few weeks or so. Still, correctional officers and guards and medical staff come in and out of the facility every day. So we have this confluence of almost, as the cliche goes, a perfect storm. So we know there's a high prevalence of behavioral health disorders, mental illness, and substance use disorder. And we also know that a lot of correctional populations have chronic physical health conditions, and that those include asthma, hypertension, diabetes, and cardiovascular disease. So the co-occurring disorders that folks have in incarceration settings really makes this population particularly vulnerable to adverse consequences from COVID-19. So I put this slide up just to demonstrate that, and this is true for prisons especially, but we're also seeing this in our county jails, the phenomena of aging of our criminal justice population. And I just put this up to show that in addition to a lot of the conditions we've been talking about, and in addition to opioid use disorder, we also have a disproportionate number of older adults who have been sentenced to lengthy sentences and are now aging in the criminal justice system, or folks who have been incarcerated in our county jails who are older adults. So what do we do about this? So we know that there are a number of problems, a number of challenges that we've identified. So some of the things that we can do in a more immediate time frame. So there have been lots of calls for releasing folks to the extent that we can do so safely. So who should be prioritized? Well, individuals who have serious underlying medical conditions, in addition to substance use disorders. So we know a lot of folks have underlying respiratory issues, cardiovascular disease, other things in addition to substance use disorder, which could make them especially vulnerable. As I mentioned before, older individuals, really anyone over 50, who do not pose serious threats to public safety. We know as individuals age, the likelihood of them committing new crimes after they're released is exceedingly low. And individuals who are nearing their anticipated release date within a few months or a few years could have expedited release. And then, of course, individuals who are non-violent, especially those with substance use disorders, and or who have relatively minor technical violations. So these are some areas, and I should say that a lot of this is occurring across the country in both prisons and jails in numerous states, where folks are taking a step back and really looking at their correctional populations, trying to figure out who they can safely release, and also in partnership with law enforcement, prosecutors, and the courts, trying not to arrest or incarcerate folks for low-level nonviolent offenses. So it's a great ideal scenario, these 4 bullet points, and then some additional ones that are not shown here, but we all recognize that it's not so straightforward. So in addition, really what we want to do is de-densify, essentially. So we know that correctional populations are very densely packed into facilities. So how can we potentially reorganize individuals into smallest possible units? And that will facilitate better social distancing. Obviously, it's not ideal, but if we can get enough folks out of our facilities, then potentially we can employ some degree of social distancing. However, we want to be careful not just to rely on social isolation and quarantining folks in solitary confinement. And there's been some discussion about this may actually discourage people from reporting symptoms because of potential fear of being put in solitary confinement. Again, we just mentioned freeing up space for the purposes of isolation when needed. Really, education and implementation of routine screening, particularly for those at higher risk. This is regular temperature checks, symptom screening, access to personal hygiene products, especially soap, free of charge. Most correctional facilities prohibit hand sanitizer and other sanitizing products because of the alcohol content. So that's very controversial. It's considered contraband in many areas, but at the very minimum, provide adequate access to soap. Also, waiving copays. There are small copays, but nevertheless, they can prevent people from seeking medical care. So we want folks to immediately report symptoms. And then use of telemedicine as much as we possibly can to provide medical care for non-emergent and behavioral health issues. So I want to really focus in on telemedicine and e-prescribing, and this is of particular relevance in the post-release period. So over the last few months, actually, SAMHSA and the Drug Enforcement Administration have released guidance for e-prescribing of controlled substances, which includes buprenorphine, without an in-person medical evaluation. So this has been a change, and it's been a direct response to the COVID-19 pandemic. Now, this does not apply to methadone. Methadone still requires an in-person physical, but for buprenorphine, actually, this can be done through telemedicine e-prescribing initially. Also, Health and Human Services has relaxed HIPAA restrictions so that it's becoming easier to use other video platforms for telehealth. So there's been a lot of challenges making sure that telehealth platforms are HIPAA compliant. And while that is sort of the standard, and we want that to really protect confidentiality, in times like this, when we're facing a really crisis situation, there have been opportunities to use things like Skype, FaceTime to deliver telehealth services. And also the counseling piece, of course, that's most easily delivered through telemedicine. And, in some cases, even though different programs have different requirements around this, we need to really be considering waiving counseling requirements if it's not available via telehealth. Again, the counseling, as we know, is an essential part of recovery and treatment. However, if it's not available through telehealth, we also have to weigh the risks of in-person versus remote visit. Assess risk for overdose on an ongoing basis. Again, you can use telehealth for that, telephone checks, and ensuring access to naloxone, particularly if people are isolated and they don't have folks to administer naloxone around them. So how are they going to be getting access? Do they have folks around in the event of an overdose event? And then potentially waiving toxicology screenings for patients who are stable, who have been doing well in treatment. And then, of course, considering longer prescriptions, particularly for buprenorphine.
Thank you, Nick. That was really great. So we'll move on now to the next section, which is going to be done by Nicolas Terry, who's the Executive Director of the Hall Center for Law and Health at Indiana University McKinney School of Law. He'll be going over the legal and policy environment around these issues. Nick?
Thank you, and it's great to be with you all. Let me start by saying that I agree with everything Dr. Zaller has said, and would like to double down and emphasize so many of his points. I guess two frames may be useful here to understand what we're looking at. The first is somewhat uniquely, I suppose we should be pleased that it's somewhat unique, we're actually dealing at the moment with concurrent public health emergencies. We have our substance use disorder overdose public health emergency, accounting still for 70,000 deaths per year. It's increased rapidly during the last decade, probably peaking now, but relatively flat going forward. And now we have a second public health emergency because of the coronavirus caused by COVID-19. The estimates, as you know, change daily and are politically fraught, but are we talking about 100,000, 240,000 in 2020? And who knows what happens thereafter? Do things drop off radically? And so perhaps the SUD overdose death numbers continue to be the most tragic, or do we have a much longer tail with COVID-19? The other frame I would suggest with specific regard to our topic today is that, as it's been called by my good friend Leo Bolesky, we have a sort of a nested pandemic problem when we look at the general population threatened by COVID-19, and then within that, this highly vulnerable SUD jail prison population. I invite you to, pick your own metaphors. Is it a lockdown within a lockdown? Others have referred to the prisons and jails as a reservoir of infection or petri dishes. We have to look at this vulnerable population much the way we are looking or should be looking at other vulnerable populations, like those in homeless shelters, those in nursing homes. Again, these have those same characteristics of, as Dr. Zaller noted, population density and difficulty of social distancing. So we're looking at an incarcerated population of 2.2 million. And again, it's not static, is it? Just like, as Dr. Zaller said, the staff are going in and out, so this population of 2.2 million is continually cycling, going in and out of these facilities. Prison population with SUD, probably more than 65%. Jail numbers are far more difficult to get to, but we know they are very high. Prisons and jails are described by one judge this week as a tinderbox, full of unhealthy aging population in dense overcrowded situations, unsuitable for distancing, very high transmission rates with minimal containment potential. And as already mentioned, These are places with an exceptionally low rate of SUD treatment, plus a troublingly low level of general health care. Again, now making mitigation challenging. It's also a highly fragmented system and hence population. We have federal prisons, federal ICE detention facilities, state prisons, local and county jails. Could have the next slide, please. The current state, as with everything COVID-19, everything is changing every day. We have quite incomplete data overall. It appears that infection rates and deaths of inmates and staff are rising fast, but this is not a system, the correction system or jail system, that tends to be particularly transparent. An exception, I think, could be argued for the California Department of Corrections and Rehabilitation that actually has a tracking system on its website showing which prisons or which jails, I beg your pardon, which prisons have the highest number of infections, deaths, and so on and so forth. So there's some really good sort of public health dashboarding going on there. Judicial proceedings have slowed because of emergency procedures in place. That, of course, is of some benefit to those who are bailed out at the moment, but those who are in custody are seeing a much longer time in jail. A small number of states and local law enforcement have defaulted to issuing summons rather than arresting those suspected of low-level nonviolent property crimes, prostitution, drug crimes, and so on. But it is still a relatively small number that have at least publicly admitted to that kind of policy. Some states, New York being the obvious one, have suspended in-person probation and parole visits. But some systems are sort of doubling down. They rely on protocols. They have COVID-19 action plans. Probably the best example here is the Bureau of Prisons, the Federal Bureau of Prisons, which has now moved to phase 5 of its COVID-19 action plan, building quarantine facilities and so on. In contrast, again, the California Department of Corrections and Rehabilitation, while explaining in its own policies and publishing its own policies as to how it's dealing with those who remain in the system, within that document also explains its policy with regard to releases, early releases, and so on. So some cities and counties, relatively few, are acting to reduce jail and prison populations. The most recent large number is in Harris County, Texas, where a judge has ordered release of 1,000 nonviolent inmates, and we're seeing other sort of patterns develop. Exactly what criteria these release plans apply is difficult to tell. Some seem to be relying on a high risk of transmission. Others focus more on the low level of charges, releasing those convicted of misdemeanors, minor drug charges, probation violations, or providing early parole for some. But again, as noted by Dr. Zaller, this is a very dangerous strategy in many ways, as we risk the very high risk of overdose on the release of this vulnerable population. They are released even in the best of worlds, not a COVID-19 world, into a very dangerous environment. Lack of secure housing, they possibly will join the homelessness, merely exacerbating problems within a second vulnerable population with its own high SUD rate. Typical SUD services such as meetings, outpatient care, are typically shut down during the pandemic. So I think we have to pivot from the typical kinds of services that we see on release, including Medicaid, Medicaid managed care, stuff that the next speaker will be addressing, and see if we can pivot to novel types of release, sort of providing packages with details about virtual services, housing, naloxone, putting in fentanyl test strips, and of course, making sure there is extended release naltrexone upon release. I suppose that some, but probably very few of those returning to some kind of treatment environment may benefit from the SAMHSA waiver, allowing take-home doses of methadone placed in lock boxes and so on, together with the DAEA relaxation of the buprenorphine rules, particularly geographic limitations on licensure, using telehealth, and now most recently the new DEA relaxation allowing telephone even on the first contact. And interestingly, even in places where they're not generally viewed as legal, syringe exchanges have been deemed essential services. If you want to dip into the law, you need to go to the 8th Amendment, where there is a series of cases that impose a sort of a deliberate indifference standard to the health and safety of inmates. Essentially, it's more than negligence. It's more is required to be proven than mere negligence, mere medical malpractice. And it's sometimes referred to, this is the Farmer and Brennan statement, as subjective recklessness. We are seeing suits being filed across the country referencing COVID-19. For example, a single case brought in Oregon by a diabetic man. In California, Judge Mueller there is overseeing multiple cases filed to reduce prison populations. Probably the most interesting hit we saw lately was Judge Johnny Jones in the Middle District of Pennsylvania, Federal District Court, in an extremely well-reasoned opinion that is probably good reading for anyone who wants to look at this issue, ordered the release of 13 persons in ICE detention in various jails because they were at particular risk if COVID-19 was to be transmitted to them, because they were suffering from, amongst others, diabetes, they were immunocompromised and so on. And he said there was no doubt but that there was a public interest in these folks being allowed out. Governors, probably slightly more politically inclined, seem uninterested in using their broad reprieve powers to facilitate early releases, but as this situation develops, they may have to change their minds.
Hey, thank you, Nick. That was great. And with that, we'll move on to our final speaker, Jodi Manz, who spoke at our last two webinars as well. She is the project director of chronic and vulnerable populations at National Academy for State Health Policy, or NASHP, and she will be discussing state Medicaid considerations. And with that, Jodi.
Thank you, Ken, and thank you to the previous two speakers. That was fantastic, and thank you to the FORE Foundation for hosting this webinar today. This is a lot of really important topics being discussed today. So do we want to go to the next slide? Thank you. So one thing that would be very helpful to support folks who are transitioning out maybe early and unexpectedly from incarceration settings would be to have immediate access to coverage for care, particularly if those folks are on buprenorphine replacement therapy or need access to oral naltrexone or follow-up care. Particularly in this environment, finding those services and accessing those services has gotten more difficult, to the point of the previous speaker. So having Medicaid would mitigate some of those challenges. The challenge for that for states is that there is something in federal Medicaid regulations called the inmate exclusion. This is why folks who are incarcerated at any level, whether that's a local jail or state or federal prison, do not have their services covered by Medicaid. This is why you're seeing all of the treatment programs that do exist, that are fantastic in many local jails and state prisons, are usually funded through federal grants. STR and SOAR grants have supported a lot of that, as well as grants through the Bureau of Justice Assistance, because Medicaid can only cover services if someone has to leave the facility, say for an overnight stay in a hospital. So states need policy levers to be able to quickly ensure coverage upon reentry. The good news is that for most states really, there's a policy of suspension rather than termination, where if someone goes into the jail already being covered, jail or prison already being covered via Medicaid, those folks essentially have that turned off while they're incarcerated, and it can be turned back on. In 23 of those states, it can be turned back on via an automated data exchange, literally the day or the week that folks leave. However, the caveat there is that folks have to have that coverage when they go in. And because Medicaid expansion is relatively new for many states, or folks just didn't have access or for whatever reason were unable to be enrolled previous to their incarceration, that lever doesn't really work for those folks. Next slide. A few considerations, and some of these have been touched upon previously, but when we're talking about Medicaid enrollment for folks as they reenter, it's important to recognize that there are very different realities for jail versus prison populations, which absolutely affects the implications for their reentry. For states, particularly those without unified incarceration systems, where the jails and prisons are under one authority, that's pretty rare for a state to have. The experience of reentering from a jail will be very locally focused because those jails are funded and administered usually by local entities, whereas prisons are generally, excuse me, allergies, whereas prisons are generally covered and administered by states. So eligibility for this population is not likely for states without Medicaid expansion. For states that have expanded Medicaid, you likely can find eligibility for these folks. They likely do qualify, but for states without Medicaid expansion, that's a little bit more difficult because they have to find another categorical form of eligibility that may or may not exist. The other issue is that Medicaid applications are not processed instantaneously. So for folks leaving jail today and being able to access applications and services in kind of a perfect world tomorrow, that application still will not be processed immediately. So while some states do have an infrastructure to support enrollment for people who are close to reentry, some don't. There are some innovative practices that we'll talk about on the next slide to help folks get enrolled before they reenter. But because this is something that really has been spurred on very much by the SUD epidemic and trying to ensure that folks have coverage upon reentry, this is not an across-the-board policy. Next slide. And those policies are called in-reach. You might hear it called something like a reentry benefit. Some states have created opportunities for folks who are currently incarcerated, if they're incarcerated today, to be able to submit Medicaid applications before they're released, which would mean that they would have coverage day one. Ohio is the state that folks point to most often as kind of the model for this plan. They do pre-release enrollment and have done so, I think, for about the last 5 years. This has been in place. They do it through Medicaid managed care so that when folks leave, they have an insurance card through a managed care organization, and they use peers to help folks navigate this system in order to get enrolled. Utah just very recently passed a bill directing the state Medicaid agency to do something similar. Massachusetts and many other states are using contractors to help folks enroll, and usually this is done about 30 days prior to release because that enrollment process can have some pretty heavy administrative burdens. It's not something you can just sit down and do in 10 minutes oftentimes. But what makes this a challenge right now in particular is that to put these kinds of programs together, we're talking about cooperation between two very complex systems, between Medicaid and correction systems. And you have to have cooperation across those systems, and that generally takes time. These kinds of programs also rely on vendors, contractors, peers, local social services staff. There's a lot of coordination that has to happen among individuals in order to build these programs, and that of course takes time. Building that infrastructure oftentimes involves contracting and training, and it's not something that can happen overnight. Where I do think there may be some leverage for states to do something relatively quickly if they're trying to cover reentering populations is through a mechanism called presumptive eligibility. This has been kind of experimented with in several states. Presumptive eligibility is a concept that was kind of developed under the Affordable Care Act that says if it seems likely that someone would be eligible for Medicaid, you can allow coverage before that eligibility is actually confirmed. So before that application gets the stamp of approval, you can assume that somebody would be eligible and cover services that way. So I do think there's a little bit of promise there, and it's something to be considered in this kind of environment. Next slide. The last one for me. The other piece here that I think is very interesting, and this is a little bit of a kind of a shot down the road and a long game, but there is a lot of talk, and there has been for several years, around finding a way to waive that inmate exclusion. One of the things that you can do in Medicaid is, if a rule is something that you want to experiment with getting rid of in your Medicaid program, you can submit a waiver to do that. The state Medicaid agency submits that waiver to the federal, essentially the federal Medicaid agency. It's the Centers for Medicare and Medicaid Services. They go back and forth and kind of decide what seems valuable. And right now, there are Section 1135 waivers out there for states. This is how states are finding the authority to cover COVID, essentially, in their Medicaid programs and expand hospital services. Most states have submitted one of these by now, and they are particularly related to COVID. There's not a whole lot that has anything to do with behavioral health or substance use disorder in any of these. However, California did request in their 1135 waiver, in kind of a supplementary letter to the federal agency, to have the inmate exclusion waived. And the reason they did that was so that testing, diagnosis, and treatment for COVID services could be covered for folks who are incarcerated. Because as we've discussed today, the risk is very real for folks who are inside those four walls. That was not granted by the federal agency. But this is a long-standing health policy that it feels like we may now have some real impetus behind changing. So I just thought it was important to point that out, because even though this was not granted by CMS, I do think that it sets the stage to potentially continue to pressure the federal agencies to waive the inmate exclusion in a COVID-19 environment, and potentially eventually for other services like substance use disorder. So with that, I think my slides are done. Thank you so much.
Thanks for that, Jodi. With that, just quickly, it looks like someone commented that in addition to California, New York also seems submitted an 1115 waiver last fall, requesting those 30 days pre-release waiver.
Yeah, there have been kind of pushes to get that inmate exclusion waiver addressed for the last few years, and the calls have gotten louder, I would say, from organizations of sheriffs and attorneys, and hopefully we're seeing some renewed interest in that.
Great. So with that, we're going to jump into we have about 15 minutes, perfect, for a Q&A session. Again, if you would like to submit a question, you can do so by clicking the Q&A box at the bottom of the Zoom screen and submit your question. We ask that you look at the questions that have already been submitted first and upvote them with the thumbs up button at the bottom of each question to ensure that we're going through the rest of it. So in addition to our three speakers for our question panel, we also have with us Dr. Lauren Brinkley Rubenstein, who's an assistant professor in social medicine at the UNC Chapel Hill. So we thank her for being here to answer some of these questions. Great. So the first question that we have here submitted, and it looks like, so the first question is, how many systems are stratifying their COVID cases by race, ethnicity, sexual orientation, and other subgroups? As the justice system is rife with disparities, especially around drug use, it is likely important to know this. As we seek to mitigate bad outcomes, are we looking at culturally relevant responses and solutions? Are we looking to make sure all people have equitable access to telehealth improvements, longer-term prescriptions, not to mention the needs to look at gaps to create more equitable justice reforms overall. So I will toss that one up to, I guess, Dr. Zaller. And Jodi, you can chime in, obviously, if you think note as well.
Yeah, well, I will say, first of all, most jurisdictions are not collecting this info. Well, they're collecting information, but they're not reporting it. So, and in fact, there have been a number of calls recently. Ibram Kendi just published something in Atlantic about why don't we know more racial information about COVID-19 cases. And I think that part of the challenge is folks are just sort of reporting cases as quickly as they come in, putting them up on dashboards, and then the general public wants to know total cases, and then breaking down for gender. But the more nuanced separation of the data, stratification of the data, has not really occurred. And in correctional facilities in particular, we know even less. So I think that right now there's been a call to try to understand as much as we possibly can about who's being infected. And I think this has a lot of implications for not only community transmission, but also community response. So we have limited testing. We know that our correctional facilities are going to have limited testing. That's just a given. And in particular, some of it's important to note that some of these things that we're talking about really speak to ability to see a provider who can prescribe buprenorphine, let's say. So if you're in a place where there are disparities across who gets what type of medication, for example, methadone relative to buprenorphine. So some telemedicine services may not be available to folks who are on methadone. And obviously buprenorphine still does require having a primary care practitioner. So it really does heighten potential disparities in terms of where buprenorphine providers are, where they're willing to prescribe, and then of course who has access to healthcare. I think some of the Medicaid parameters that Jodi had mentioned are really important, and particularly in the sort of post-release period. But still, it doesn't really help if you're in a treatment desert, so to speak.
Ken, you didn't call on me, but I'm hoping that this is Lauren, that I can chime in.
Of course.
Just to sort of reiterate what Nick was saying, but also just wanted to say thank you to Kima for raising this. It's a really important point, and also Tracy, who's amazing as usual, and linked here to an important link. I also just wanted to say that there are a group of us who are really tuned into this as an issue and have been working to submit, Nick is a part of this group too, to submit some grants to collect more data, so there is more transparency around who's being treated and who has access. And so just wanted to say thank you, and there are some of us who are working on it. So also, if you're interested in getting involved in that, we'd love to have you.
Great. And
this is Nick. I mean, we haven't yet heard too many stories, have we, about explicit bias and so on, but we just know from our experience is that at times of pandemic or hurricanes like Katrina, it is the poor, it is the vulnerable who always suffer the most. With regard to the specifics of the question, even if we don't have knowledge of explicit bias, we can imagine that usual patterns of implicit bias will continue. From a legal standpoint, we do have the Americans with Disabilities Act that tries to level some of these playing fields, as well as other civil rights acts. And there was a very interesting bulletin put out on March 28th by HHS's Office of Civil Rights, reminding healthcare providers of their obligations with regard to prohibitions of discrimination on the basis of race, color, national origin, disability, age, sex, exercise of conscience, religion, et cetera, in HHS-funded programs.
Thank you. So we'll move on to the next question. So could you comment on the need for access to extended release and sublingual buprenorphine as an option at release, as opposed to accepting the idea that extended release naltrexone is the quote unquote standard and often only the only option offered. Vivitrol is heavily marketed to the states as not substituting one drug for another, but there is no evidence of superiority to buprenorphine and many concerns about limitations of naltrexone and adherence to Vivitrol versus buprenorphine. So I will toss this one up to Dr. Brinkley-Rubenstein.
Sure, thanks, Ken.
Yeah.
This is such an important issue, and again, thanks for raising it. I think I haven't seen this, but it is definitely something to monitor. There's a lot of stigma in correctional facilities around the use of MOUD and the thinking that methadone and Suboxone are in one category, and we often do hear this sort of phrase that you mentioned here, not substituting one drug for another, and then people thinking about Vivitrol as you know, a receptor blocker, and tend to think about that as more superior, even though we know that's not true, and that in fact the long-term effectiveness of Vivitrol in overdose prevention is really up in the air. And so thanks for raising this. And I think all of us who are working in correctional spaces really need to keep our eye on this so that there isn't this tendency to use Vivitrol over the other options that we have available.
Yeah, I would like to also just chime in. I would say that Vivitrol is not the gold standard by any means whatsoever. And I think largely there's been a lot of heavy marketing. And really, frankly, it's been a cost issue. A lot of the injectable buprenorphine products are prohibitively expensive for correctional facilities. If folks do not have insurance post-release, you know, that's going to be a challenge. And so Vivitrol has been able to get a foothold in the correctional space because it was the original sort of injectable medication. There's a lot of concern, obviously, in corrections about diversion, but you know that again, there are numerous facilities that have been able to get around this. There are also facilities that are using injectable buprenorphine. So I think part of it is folks being able to offer multiple medications in facilities, and anytime where there's only one medication offered, it also there are many fewer providers of injectable naltrexone in the community. So one of the problems that we've seen locally here is the preferred method in corrections where it's offered and it's very limited, but there are fewer providers who will actually see patients on the outside. So that has serious implications for continuity of care. So mm-hmm. I think that it's you know, there is no you know, I think as injectable buprenorphine products become more widely available, then I think they should be actively promoted in correctional facilities.
Mm-hmm.
And this is Jodi. If I could just add one thing,
Of course.
I love this question, and I think it's very important and highlights actually several really important issues. One of the challenges for correctional facilities is that there are no clinical indications from the manufacturer to be starting someone on a depot version of buprenorphine if they haven't been on an oral or sublingual version, which means that you have kind of a twofold need in that incarceration setting, and that's to be able to provide that bridge for folks, which requires setting up systems and contracts and just some administrative challenges. But I do think, to the heart of this question, we're seeing a lot of policy changes happen very quickly because of this epidemic that are things that people have been pushing for a while, right? And it turns out that in an emergency situation, they end up being good ideas. So I do think that this is a place where we probably will see some shifts in correctional settings, and I will do my best to keep tabs on them. So thank you for this question. I think it's really good.
Thank you, Jodi. Probably can squeeze in two more questions. So one, I'm going to toss up to Professor Terry. What roles may there be for drug and recovery courts to contribute to the changes underway in correctional SUD treatment programs and policies outlined here today?
I think there are a lot of very good people working in specialty courts, but it is not a one-size-fits-all kind of solution. specialty courts, diversion through drug courts, are not for every person suffering both from SUD and from the criminal justice system. It very much depends upon careful selection of those who go through, of the clients. It depends very much for success on the judges involved, the extent to which they've been educated deeply into the medicine and the pathology. And it requests, for the best cases, judges to resist playing doctor and to allow the experts to be in the place. So it's not the magic, the silver bullet that is often imagined. That's not to diss some people doing really good work in this space, but we need to educate the criminal justice system more generally, and prosecutors and law enforcement more generally, if we're to make a dent here. And during a pandemic also, goodness knows just how many of these courts are even up and running.
Mm-hmm. Great. We're gonna get one more question in here. This is for Dr. Brinkley Rubenstein. Can you highlight some of the work in this field being done by predominantly red states?
Yeah, thanks, Ken. Thanks, Robert, for the question. Nick can probably chime in too, so I'll try to go pretty quickly. In North Carolina, we've seen a number of jails work really quickly to let folks out, particularly people who are on pretrial detention, and then also reviewing cases for people who have low-level charges, and also trying to let those people out pretty rapidly. We've seen less of that happen in the state system. It's a bit harder to just, to let people out at the state level. You usually have to go through a parole board, and so there's been less of that. We have seen some unfortunate relying on solitary confinement as a quarantine method, but it really is because there's an extreme lack of tests. And so I've really been on my soapbox this week around the importance of getting really robust, rapid 4-hour testing in our jails and prison systems. They have tests, but they're taking a week to get back, which in many ways renders them really useless. So, and I've seen in our jails, MOUD access can remain the same, but there's really been a halting to any expansion of programs.
Yeah, I think I would just echo what Lauren just said. I think that the county jails are in unique positions to respond a little bit more quickly than prison systems in a lot of jurisdictions. We've seen similar kinds of movement locally here in Arkansas, although I will say it's somewhat complicated by the fact that it's not just the county sheriff, it's county administration, and it's also courts and the prosecutors and other folks. So trying to have a coordinated effort where everyone agrees can be challenging. The other thing that I think is really important is that we've got a lot of folks that they are being released but have no real place to go. So part of it is, do we have the resources in the community to keep people safe? And so sometimes that's a challenge. Again, that should never be a barrier to getting them out of a correctional facility. But at the same time, it's important consideration, because we don't want to be putting someone from a bad environment into a worse environment.
Great, and it's 4 o'clock now, so we are just finishing up right on time. Thank you again to all of our panelists for joining us today. This has been a wealth of information. You can find some more additional resources here. Again, these slides will be posted on our resources page on our website directly after this. Again, general inquiries, you can reach us at that email over here. A recording of the webinar will also be available. But thank you again for attending the webinar, and we hope that you join us next week again as we continue this series. Thank you. Stay safe, everybody.